One was a study on the comparison of ALL RIC regimens for allo transplant in adult ALL, because as you know, ALL still has less satisfactory outcomes than acute myeloid leukemia. It's also a much rare disease, so also all the studies are harder to do in this setting, and we always have less data even in the EBMT registry. In adult ALL, especially in high-risk adult ALL, with outcomes overall survival which can be 30 to 40%. Today, one of the standard of treatments is allogeneic stem cell transplant, and is usually offered to the high-risk ALL patients, because it has been shown before that especially myeloablative stem cell transplantation improves their outcomes. Of course, not all patients, especially older patients and patients older than 45 years old, can undergo myeloablative stem cell transplantation. So there is reduced intensity conditioning allotransplant that can offer them cure to these patients. However, when we talk about reduced intensity conditioning, we always fear from higher risk of relapse because of reduced intensity conditioning. And we have several reduced intensity conditioning regimens. The three most used are the combination of fludarabine and busulfan. The other is fludarabine and melphalan, and the third most used is fludarabine and TBI. And so it is usually used according to institutional practice. There are, of course, no prospective studies comparing those three regimens, and we only have single center experiences on those regimens. And if you have available all three and we are wondering which is the best, we actually don't know. Some of the studies retrospective that exist are contradictory, and that's of course because it's not only usually not only ALL, it's many when you compare conditioning, it's usually many diseases analyzed together. So in the EBMT setting, we wanted to analyze the data set that we have and to compare those three most used RIC regimens in ALL. So we did. We identified about 400 patients, all RIC ALL patients, so patients older than 45 years old who went to allogeneic stem cell transplantation in CR1 and who got one of those three regimens. Of course, those patients, we had to have some minimum data on these patients as their Philadelphia status and their immunophenotype at diagnosis as well. And we analyzed related and unrelated donors and peripheral blood stem cell recipients to have a more homogeneous group. And when we analyzed those 400 patients, we had about 200 flu-mel patients, 119 flu-mel patients, and about 100 flu TBI and flu-bu patients. And when comparing those three groups, we saw similar outcomes in terms of overall survival, leukemia-free survival, relapse incidence, transplant-related mortality, acute GVHD. The only difference that we saw was actually less chronic or more chronic GVHD in the flu TBI group. However, flu-bu patients usually receive in vivo T-cell depletion with ATG. Flu male patients usually receive in vivo T-cell depletion with compact, and flu TBI do not receive usual in vivo T-cell depletion, and that is the reason, because in multivariate analysis, when this is adjusted for T-cell depletion, then this difference is lost. So our results are some of them correspond to previous studies. Some of them are slightly different, but it is so far the biggest multi-center analysis that shows us that those 3 week regimens have similar outcomes. Of course, our outcomes are not satisfactory, because we have survival which is around 50%. That's overall survival between 50 and 60%, and lower leukemia-free survival, which also tells us what we know, that those outcomes need to be improved further. And today in the ALL setting, we know that we can do it before transplant by reducing minimal residual disease with new novel agents that we have today, like inotuzumab, or to follow up also these patients closely and to do prophylaxis if we can. Prophylaxis meaning as TKI inhibitors in Philadelphia positive patients, or preemptive treatments in patients who develop minimal residual disease post-transplant, like interventions like post-transplant DLI, or some of those drugs that I mentioned used in preemptive post-transplant setting as well.